Correct. So we'll wait just a couple minutes to see if we have others join, but I'll start with just some overview and introduction. So there are no new board members to welcome this month. So this month we have all originals, everyone from before. And so while we're waiting for everyone to join, we also like to do some share our names, pronouns, and we'd like to do an icebreaker question. So today's icebreaker question is, what are you known for, or what do you like to bring to potlucks? What is your signature bring to or go to going to potlucks? I will start. My name is Veronica Irvin. I'm from Oregon State University. I go by she, her pronouns. I like to bring quiche to different potlucks. Some either meat, like essentially bacon and eggs in a pie, or vegetable. And I enjoy bringing those to potlucks. Who would like to go next, sharing their name, pronouns, and go-to dish? Jocelyn, excellent. Dr. Warren.
I'm Jocelyn Warren. My pronouns are she, her, hers, and I'm from Lane County. And my I don't have a go-to. I would love to go to so many potlucks that people actually know me for something. It would be fantastic. But we did have one in our WIC office yesterday, and I found a new recipe which I loved, and it was a watermelon salad with tomatoes, cucumber, olives, which was new. I hadn't done that before. Feta, a little mint and parsley, and olive oil, and red wine vinegar, and it was quite delicious. So I highly recommend that.
That sounds good. The olives and the watermelon? Yeah, I like that.
And tomatoes. It was really yummy. Yeah.
That sounds good. Thank you, Jocelyn. Thank you for going next too. Who else from FAB would like to introduce themselves and their go-to potluck item?
I'll go. I'm Kelly Little. I'm a representative of an Indian tribe in Oregon. I work with the Coquille Indian tribe. I go by she and hers. I'm a registered dietitian by training, and I've gotten into health administration. But my go-to is generally something reasonably healthy. For vegetables, I like to bring different salads. Salads with fruit, interesting salads.
Great, thank you, Kelly. And I didn't know, registered dietitian.
My alma mater is Oregon State.
Oh, even better. Thank you. Thanks for our program. All right. Thank you very much, Kelly and Jocelyn, for going. Next from FAB, who would like to share?
Hi, this is Nick Powers. I work for Winding Waters Clinic out in Eastern Oregon. He, him, his pronouns. Potlucks. My partner is a physician, so we tend to stay on the healthy side. I rely on my friends to bring dessert, but we usually bring just a simple Caesar salad, and we can enjoy that if we're not sure we want to enjoy anything else that's at the potluck.
Good. Yeah. Thanks, Nick. Thanks for bringing something you know you're gonna like. Thank you, Nick. Next from FAB members, who would like to go?
I can go. This is Erica Sandoval. Pronouns are she, her, and Aya. I'm the equity director for the Oregon Public Health Division. About almost 17 years ago when I moved to Oregon, I learned from some Midwest folks how to do a dip that has mayo, which I never understood, but it's delicious. Mayo and cheese and artichokes, and you just bake it, and it's absolutely delicious. Mayo. So, and it was very cost effective as a graduate student. So that's usually what we used to bring.
Excellent. That is a fun dip. Cost effective. Yeah, I'm not a big mayo fan either, but I do like it in dips like that. Thank you, Erica. Other FAB members sharing your name, pronouns, go to potluck dish.
Hi, everybody. This is Jeannie Savage, Chief Medical Officer at Trillium Community Health Plan, she, her, and hers. I would say strawberry rhubarb pie. My husband makes a mean strawberry rhubarb pie. Anytime he makes it, I'll take it with me, but I'm limited on what I'll share. I like to eat a lot of it.
Excellent. Good example. Hopefully someone will get to try this homemade pie. That sounds good. Thank you, Jeannie. Other FAB members.
Good afternoon, everyone. I'm Dean Sadlinger. He, him, his pronouns, the privilege of serving as the health officer and state epidemiologist at OHA. I guess one of my go-tos is smoked salmon dip. I use Anna Garten's recipe, which is amazing, but of course I add in much more horseradish because there's nothing wrong with extra horseradish.
Thank you for that salmon dip recipe. Excellent. Thank you, Dean. Who else do we have from FAB? FAB members, FAB subcommittee members. I think we might have Dr. Petaway, Jawad Khan, and who's that?
I have mommy. M-O-M. Mom. O-M. Yeah.
Tammy, I think you might want to mute that.
So do we have other committee members, FAB members, or subcommittee members who would like to introduce themselves and share their favorite dish to bring to a potluck?
Hi, everybody. Jawad Khan, Director of Programs, Muslim Educational Trust. Favorite dish to potlucks? I'm usually the utensils person that's bringing the utensils as a last second cop out. I'm working on it.
That is excellent, Jawad. That is something that almost always
Everybody
is needed
needs.
at a potluck. That's right. Dependable. I like that. Thank you very much. Thanks for sharing. Other FAB or subcommittee members?
This is Ryan Petaway, professor at OHSU Patriot School of Public Health. I mean, you gotta have something to drink at the potluck. I mean, you can't just eat and like not have anything else, right? So I do sangria, Pinot Noir with strawberries and plum, and let that joint sit. A little bit of cinnamon, good to go.
That sounds delicious. Homemade sangria. Very nice. Excellent contribution to our potluck. Thank you, Dr. Petaway. Other members, other FAB members or subcommittee members? If not, we'll move to OHA staff. I don't see other subcommittee members or FAB members. So how about OHA staff sharing your name, pronoun, and potluck dish?
Sure, I can get started. I'm Sarah Boudreau. I use she and her pronouns, and I work in the Office of the State Public Health Director and provide staffing support to FAB and its subcommittees. I love a good kale salad, so that's what I'm going to go with. And I'll go ahead and pass it over to Sharina.
Hey everyone, thanks Sarah. Sharina Walker, she, her pronouns, Oregon Health Authority Legislative Policy Lead. I feel like most of the potlucks I attend are with family members and I have no control over what they want me to bring, and it's always potato salad. They always want me to bring potato salad. I do make pretty good potato salad or dessert like brownies or something. So I don't know. I feel like next time I just need to do what I want to do and bring my own thing.
Thank you, Serena. Go ahead, pass it to somebody. That's perfect. Thank you.
I will pass it to Victoria.
Hi everyone, I'm Victoria Demchik, she, her pronouns. I also work in the Office of the State Public Health Director. We have become the pie people for my family's potlucks, and that is what we do.
Excellent. Thank you. Thank you, Victoria. And would you like to pass it to another OHA staff member? Let's see, maybe Tambi? Tambi.
Hi, Tambi, she, hers, and I as well work in the state, the director's office. And my go-to is actually very similar to Erica's. It's a hot artichoke dip, but I put mayonnaise, cream cheese, sour cream, a bunch mozzarella cheese plus Asiago, Parmesan, and I forget the third cheese, and then some things, and then I bake it. So that's usually what people ask me to bring. Or I am also known for my rum cake. It's really rummy. So people often ask for that as well.
Thank you, Tambi. That sounds delicious. And who do we have left from OHA staff? And looking on the sides, who else would like to go?
Well, I guess I can go.
Diana, great.
Oh, sorry.
Go for it, Diane.
Oh, Diane Leva, she, hers. I also work in the director's office, and my contributions are usually salads. I'm big on salads, and really complex salads with a lot of ingredients and wine. You know, and depending whether it is winter,
In the winter, I tend to bring more full-bodied wines like a Grenache or a Montepulciano. And in the summers, I go for the white wines. Thank you.
Thank you, Diane. It's good to know your wine, all the details on your wine connoisseur details there.
Yeah.
And who else was going from OHA staff? I heard someone else talking also.
Dana Drum. I'm Dana Drum. I'm the local and tribal public health manager and here for the Block Grant agenda item. And I think my go-to potluck dish lately has been Derby pie, which is a Southern pie that has all the good things: eggs, sugar, flour, butter, and a little bit of bourbon. And chocolate chips. That was the other thing, chocolate chips, and sometimes nuts.
That sounds good. Thank you, Dana. Drew, are you, I was looking to see, I think I see Drew and anybody else from OHA that hasn't gone yet?
Yeah, I'll go. Drew Coutman, he, him. I'm a fiscal analyst in the director's office. And because I have a 3-year-old, the thing I'll be bringing will be baked mac and cheese.
Excellent contribution to the family side. Thank you, Drew. Anybody else that I'm missing on our call? Okay, then we're gonna get going. That was a fun and easy task. The next task is now we need to have a potluck. Yes, Kelly. Now I'm hungry. We need to have a potluck together once we're back meeting again and eating. Kara and Tambi are continuing to work on identifying another standing meeting time. Please reply to Tambi's individual emails. She's been reaching out to everybody to align schedule. So please look for an email from Tambi. I'll be honest, I'm not sure when our July meeting will be held. Right now it's at the original time, correct? Okay, at the moment it's still the original time. Today we have a lot of information, a lot to do on our agenda. So to that end, today we're not including the standing item discussion time for FAB member topics, but we'll bring that back in our July meeting. Thank you very much for your flexibility. And we'll be focusing today on questions from our health equity review and policy procedure. Sarah, can you confirm if a quorum is present?
We have 8 of 13 voting members, so we do have a quorum.
Excellent, thank you. And do I have a motion on the May minutes? And actually any discussion on the May minutes, and I did want to note, there was some, when I looked at it, there wasn't correct on who was present and who was absent. So making sure that got corrected on there. Any other edits to the May minutes? And do I have a motion to approve?
So moved.
Great, thank you, Kelly. A second?
Jeannie, I'll second.
Okay, Jeannie, and then if those in attendance, if you'll say aye or raise your hand if you approve the minutes.
Aye.
Aye. Any abstention? Anyone in abstention? Anyone not vote to approve the minutes? Okay, thank you. Moving on to our next item is the biennial report to the Legislative Fiscal Office. Oregon statute requires OHA to submit a report by June 30th of every even numbered year to the Legislative Fiscal Office, that is this year. FAB assists with developing several of the products involved in this report. That includes the local public health authority funding formula, estimated amount of funding needed for foundational capabilities and programs for the next biennium. That's 2023 to 2025. So we'll be discussing today our request for the 2023 to 2025 biennium. Sarah will share the context of the report and the subcommittee representatives will walk through each of the deliverables. So we'll have the local public health funding formula and the accountability metrics framework. And we have discussed some of the metrics and funding formula at previous monthly meetings, so we'll kind of focus on some final changes. So Sarah, I'll pass it over to you and then we can decide which subcommittees move over next.
Great, thank you. So hopefully you've all had a chance to kind of glance or flip through the draft report that we shared with you. So you have a sense of what this report has. As Veronica shared, the this report that we submit every 2 years is really in two pieces. And the first piece provides updates on our current investments for public health modernization, including how much funds we received, how those funds have been allocated and used, where we're making progress. Then the second piece of the report looks forward to the next biennium, and it outlines the work that we believe we need to do to continue moving public health modernization forward and to continue our efforts toward eliminating health inequities. It provides some information about the priorities that FAB provided earlier this year, and it also provides the estimated cost for being able to do the work that we've outlined needing to do. Let's see. So we had a chance to talk with the Conference of Local Health Officials this morning and walk through each of these pieces, and it seemed to work to talk first about either accountability metrics or the funding formula, and then wrap things up by looking at the report itself. And although I don't think it's on the agenda, but I believe that Jeannie agreed to give the update for accountability metrics, and then Veronica for incentives and funding.
Yes, and Sarah, can I ask a quick question? For each of these, is this what we will be voting in these pieces here as well?
Yeah, so it's a formal action to approve the funding formula and approve the update that we're providing on accountability metrics, which will go into the funding report to Legislative Fiscal Office. And then it's an action to recommend that OHA move the funding report forward. And so for each of those in the meeting packet, you have the FAB Health Equity Review questions for discussion.
Great, thank you. Which committee would you like to go first, Sarah? Or which subcommittee?
I think in our packet, accountability metrics is first.
Great.
And Victoria is controlling the slides so she can move down to where those show up.
Great, and thank you for including in the packet the health equity, the response questions. So maybe we can pull up the information that was filled out about the health equity review of this decision, and then pass it over to Jeannie to discuss. Then we have member discussion and then vote on this piece. Okay, great.
Well, I'm just going to review quickly a little bit about what we did in our meeting, and then we'll look at this form specifically, but I'm just going to kind of cover some discussion points that we had there. I think suffice to say that we are in agreement that a lot of work needs to be done to look at the metrics, accountability metrics, and key indicators, and making sure that those are in alignment with our well, first of all, the state's goal of ending health inequities and disparities by 2030, right? We have a vision from our state, and two, that we align those with our state goals through public health as well. So in general, we are continuing to develop a new framework and selection criteria for the public health accountability metrics. We are looking at indicators that bring attention to high priority conditions and areas and conditions, and looking at specifically to improve conditions for people who have been marginalized. And then we're also looking at accountability metrics of our government public health system and the core functions of that public health system, and trying to make sure we keep ourselves accountable to that. We did, during this discussion, clarify that our accountability metrics are for our state and local public health authorities, and that CBOs, as our important partners in this work, but are not necessarily considered governmental public health system and not part of those accountability metrics. The subcommittee talked a little bit about different selecting indicators that focus on our context, and we looked at this framework a lot, and focusing on context and not necessarily individual behaviors when we're looking at different measures and indicators. And this would include measures of differences in perhaps disease rates between racial groups, or based on risk factors such as housing status. We do also discuss that we would be begin hearing from our CLO partners and their committee to discuss the state and local public health process measures next month. And we also discussed that our OHA is including the updated metrics framework and the public health modernization funding report, which you all saw just a little bit ago that Sarah put up. We spent a lot of time with this page. Anything from my partners that I didn't capture in those kind of few discussion points? All right, so Sarah, anything else I should review here, or do you feel like I captured the gist?
I think you captured the gist. The only thing I would add is that, you know, in every other year when we've submitted this funding report, we've been including, you know, actual metrics. And that is where we thought we would be when FAB started this process to update metrics a year ago. But these very deep conversations and learning and exploring are just taking, you know, a lot of time, and that's good. We are going to continue to try to have metrics in place by the end of the year. So FAB would be, you know, potentially taking a vote to approve metrics toward the end of this year, and then we could work on producing reports starting next year and moving forward.
Thank you.
So this is Veronica. Thank you for the overview. And that was one of my questions I had, was the specific metrics. So today we would just be voting on the layout of the framework, the way that the indicators were displayed, or these definitions that we went through in here. But then there would be follow-up meetings later in the year with the specific metrics, and that would still be in time for the next biennium. That would still start 2023.
It would allow us to have metrics in place and start collecting the data. Yeah.
Thank you. Other discussions or questions from the other FAB members or subcommittee members?
This is Jocelyn. I was just struggling with this. It seemed this is a really challenging area, just in terms of rethinking how we do these measurements so that they're not focused on individual level outcomes, but really capture work that's done at the system level. And I just wonder if we need to have a few longer meetings rather than monthly meetings that are shorter, because it feels like we spend a fair amount of time kind of resetting every time we come together. And maybe this is a conversation for the subcommittee as well, but it is hard to wrap your mind around, and it seems like it takes a little while to get into that frame of mind, and then, you know, meeting's over. So because I know if it doesn't feel like necessarily like we're making as much progress as we should be on these, and I just want to throw that out there and see if the subcommittee might want to consider a slightly different approach for our meetings potentially.
Yeah, this is Jeannie. I agree. I think if we could actually give Sarah some time where we could actually sit down, because I think the hardest part is that she's trying to herd cats. And so maybe if we can all look and just really prioritize this, get maybe 2 hours in at one particular sit down, that might be more helpful for us to go forward. Jocelyn, I agree, because just when you are kind of sitting and getting in the rhythm, it's over. So maybe one more 2-hour meeting to kind of put together the indicator and accountability metric discussion would be helpful. Sarah, I can see Sarah going, yes, please do that.
It is a lot of herding cats for sure. Yeah.
Other discussion or questions from committees, from the FAB?
Veronica, do you want to look at the health equity?
Sure, that sounds good.
Just so Victoria can keep the slides at the right place. Do you want to look
Yeah,
at the
sounds
health
good.
equity questions and vote on this? Or do you want
Yes,
to?
that sounds good. We could look at the health equity questions, and then Sarah, if you can make sure that we're voting on what we're supposed to be voting on here. Okay, thank you. Like what? So Victoria, if you can move to the health equity response questions. Great. This was for, it's actually for the public health accountability metrics. And this was also in your handbook, or I'm sorry, meeting materials, and discusses again the primary changes, which health inequities were discussed, and how the work product engaged other sectors or other community members.
So I think this is a little bit, once again, I'm just going to say, I think this is a little difficult because we don't have metrics that we've already decided on. But so what we're voting on is that the adjustments that we made to the process for developing the metrics and indicators relies on this backdrop. So I just want to be clear that we know what if you agree with the way this is written out, then in the metrics subcommittee, we are going to take this information. We are going to continue to take this information and apply it to metrics and accountability metrics and key indicators to make sure that they are in direct alignment with this layout. So we are voting on, everybody in this needs to make sure they agree with this, or if not, we bring it up for discussion and make some changes. Does that clarify more?
Thank
Sarah?
you very much, Jeannie. I appreciate that. I think that sounds
Okay.
very well. And
Okay.
Sarah, for voting, are you good with raising a hand or the reaction button?
I think I can capture it that way.
Great.
Yeah.
Is everybody comfortable with so what we're going to move to is voting on this piece, which is how Jeannie has said very well. There are changes to the discussion and how they're moving to develop or identify the indicators and metrics, and making sure that FAB is in agreement with this. And this proposed changes would go into the report, but we would see the specific metrics later in the year and vote on that. So we're voting today only on these metrics, the plan, and the changes to the methods and how to identify and looking at what to propose. So if we could do all those in favor, if you could please either raise your hand in the Zoom screen or raise a reaction button to let Sarah know that you are in agreement. Sarah, are you good on those counts?
Yes.
Okay. And any counts for to vote against this current decision and to continue discussing? Kelly, I see your hand is still up. There you go. Vote to not pass and to continue discussing with changes. Okay, how about any wish to abstain? Any members wish to abstain? Okay. Sarah, do you have everything you need for that vote?
Well, I think we had 6 members approve, 1 abstain, and 1 not respond.
Okay. So it passes then. We just need majority.
Yes.
Great. Okay. So thank you, Jeannie, for the review, for the overview of that. And I think now then we'll move to incentives and funding subcommittee. I'll be representing our group, our subcommittee on that. And so our metric subcommittee actually has 4 discussion points, and I want to go over 4 pieces, but we're not proposing that all of them are done. We want to tell you know what we've been thinking about. The first that we've come to this meeting before is that the change in FTE and infrastructure funding. This change would provide sufficient funding for every LPHA to hire additional staff. OHA estimated as a starting point $200,000 per biennium for a full-time employee. And this would be beginning at the funding level of $20 million. This change would raise the base for each LPHA to $200,000. With $40 million or more allocated through the funding formula, the base would increase to $400,000, which would provide funding for approximately 2 FTE. So that's the first piece, the FTA infrastructure funding, raising the base. And I'll come back to that, but that is one that we are wanting to put into place should our funding increase. The second item that we've been discussing quite a bit in our group is the migrant and seasonal farm workers. And our subcommittee has been discussing whether to use the number of migrant and seasonal farm workers as an indicator, to add that as an indicator to the funding formula. Migrant and seasonal farm workers are not included in the county's population count, and LPHAs often do extensive work with workers, employers, and other partners to serve this population. Last week, our subcommittee heard from OHA staff in programs that work with migrant and seasonal farm workers during the COVID response and what data is currently available. The subcommittee determined that we don't have sufficient understanding yet of the data in terms of how recent it is, how often it's collected, just the depth of it, in order to add it to an indicator. The subcommittee is interested in continuing to explore the idea of migrant and seasonal farm workers as an indicator, but at this point, it's not requesting that we add it into our proposal to add that as a formal indicator. What I would like to know is if the board would be interested in hearing from, at an upcoming meeting, OHA staff and LPHAs who work with migrant seasonal farm workers, discussing what's being done and discussing what data is out there so that this could be considered for a future revision to the biennium. Any questions on the migrant and seasonal farm worker? Because I probably won't cover that much more in the sense that we know it's important, but we're not sure yet how about the data, and we really want to have more thoughtfulness on this before it's put into the funding formula. Any questions on the migrant and seasonal farm worker piece?
Veronica, may I ask?
Yes.
I absolutely agree that that is an important consideration, and wondering about the idea of singling out a single population as, for example, like there are also additional kind of needs and activities on a public health department based on the number of unhoused people in their jurisdiction. It's just another population that requires sort of an additional level of service provision. And just wondering if the committee has had any discussion about, identifying just one single population rather than, I just don't know, how that population becomes prioritized over others.
That's a great question, and we had not discussed that. I think something that we had been brought up was that they're not included in a lot of the counts that would be going into the other metrics, but that is very well true, possibly for the unhoused populations that you have brought up, and that so we have not discussed that point. I think that's a great point, and I would like to include that when our subcommittee continues to meet about this, to include that as another discussion point as well. And the idea about, I think that's a great point. Thank you, Jocelyn.
Thank you.
Other comments or questions on the migrant and seasonal farm worker piece?
Veronica, I have two
Kelly,
questions. So for the migrant and seasonal farm worker, does that capture other migrant workers in addition to those that may work on agriculture and farms? Because there are those that may be working in an undocumented status for the forest industry or in fisheries or in meatpacking or other industries as well. And if so, that's great. I just wanted to make sure that that was another area. And then also calling out this population in addition to those that were disproportionately impacted by health inequities, such as Indian tribes and what that looks like as well.
So Kelly, thank you for both those points. I do not have the answer to your first one about is it just seasonal farm workers? I guess from my notes, it's everywhere written seasonal farm workers. So that made me think that we have not discussed those. So that's a great point. And that is something that we can also ask OHA about in terms of the data and the collection and those processes. So that's a great point. And then I think your point back to kind of what Jocelyn did, but the idea about just one group and should we look at other disproportionate groups that are experiencing inequities. So I'm going to specifically the tribe. So I will put that down as well. As notes. Great questions.
Thank you.
This is Erica. I can actually answer that. So it's inclusive of it's migrant seasonal farm workers, agricultural workers, canning, so it was inclusive of that. It's just that when the group had formed at the beginning of the pandemic, the acronym was MSFW, and so they just kind of kept that moving forward. But there was a conversation. There were a few conversations, and with the governor's office last year as we were preparing for the vaccination rollout to ensure that it was an agreement that it was all of these workers, because some of them are not seasonal, they're year round. Canning is year round, and so it was inclusive of all those efforts. The question I had is if the data around the rapid community assessments were shared as part of the presentation for the committee.
We had a summary report, but we did not go over the details. They went over a little bit more about the programs and then a little bit on the variables. And I think that's why we weren't comfortable with, we didn't have enough data on that piece. So I think exploring that. So I think that's a great question. So thank you, Erica, for clarifying that. And I appreciate all these comments, which I'll take back to our subcommittee. Again, we won't be requesting any of these changes into this biennium, but these are all great points for us to consider for our subcommittee for the next biennium in 2025. Other comments or questions on this piece? Thank you for a very rich discussion and questions on this. That was helpful. The third piece, the third items, I would say they're 3 and 4 together. And this is where then we look specifically at the indicators. And our questions for the indicators were, one, is the way that's distributed, the percentages, weighted correctly? Should we change the weighting of the indicators? And the second piece of the indicators is, where's the data coming from? And in most of these cases for the indicators, the data is coming from national data sets, a lot of census data. And our question really was, are these timely and are these appropriate for the reach of who we want, for the details that we need at the county level? So for the committee, we're not changing the data sets on this. We're not requesting to change the data sets on this biennium request, but we are having OHA explore more local and timely data sets that could be used in future bienniums. So we are not requesting a change to the data sets at this point. We are requesting or discussing changes to some of the indicators. So we are recommending changes to how indicators are weighted in the current funding formula. Currently, all indicators are weighted equally. I say that, but now I'm like, I think there's a couple that were weighted a little bit more. But the recommendation is to decrease the weighting for the 2 indicators required in the statute, health status and burden of disease, and thereby increasing the weight for the indicators, the other indicators in the FAB formula. And this, perfect. So we would be keeping burden of disease and health status, kind of lowering those percents or those weights and increasing the weights in the other indicators: race, ethnicity, poverty, rurality, education, limited English proficiency. This change allocates more funds to indicators that describe the community context and the complexities of providing governmental public health services. We do have Drew on the call with us, who's been creating lots of different iterations of spreadsheets for us. And so before I move to discussing what's going to actually be in our requests for changes, any discussion on indicator on the data sets, because we're not requesting a change to the data sets on this biennium, but we are looking at doing that for future years. Any discussion on the data set pieces? So then I'll move forward with what our subcommittee is recommending as changes to the funding formula. This is going to be changing the FTE infrastructure funding, raising that base, and changing the percent of the indicator weights, shifting funding from different allocations. So we want to discuss both of these pieces and also discuss when to do it. So right now, some of the discussions we've been having in the subcommittee is to not make the changes, to not make changes if our funding is flat. If the funding is staying how it has been in the previous biennium, not to make these changes because many of the local health authorities were expecting or might have been expecting this amount. But if we were to get an increase to the biennium, an increase to our funding from the legislator to the $20 million mark, then making these changes to both the base to increase infrastructure and to the indicator weighting. Yes, and so what I'd like to do is open up the discussion for either the change to the base, which we have discussed in a prior meeting, or also changes to the percent of indicator weighting. Any questions on those pieces? And then we can talk about the timing. Any questions about changes to the funding? I will also say that this has been discussed with Chloe. Chloe has been at some of our meetings. We have not had community representation on this subcommittee. And that's something that we're looking to change. But at this point, we have not had community members outside of Chloe participating in the discussions. I'm not seeing any discussion questions or hands raised. So let me ask this question to our committee. What is your thoughts on not making the changes if the funding is flat at $10 million and then only making the changes if the funding is increased to 20 million or more? What is discussion thoughts on when to make these changes, or do we make this across the board regardless of funding levels?
Point of clarification. I thought we were currently above $20 million already.
That's correct.
Thank you.
Current funding, there's about 20.4 million going out to local public health through this funding formula. And, you know, we also use this same funding formula for other pots of public health funds. So I think the question is, you know, if we get additional funding from the legislature, you know, all LPHAs are going to see their allocations increase, and that's what we want. If we have flat funding and start making shifts, then some counties are going to have reduced allocations, and that might be something that we want to avoid. Or that wants to avoid.
And Sarah, is flat funding 20 million or is flat funding is 20 million increased funding? What does the 20 million mark mean?
That means that local public health would continue to get the 28.4, whatever they're receiving now. It means that the legislature is investing 60.6 million right now, and then that's the level that they would support moving forward for the next biennium as well.
So would we be making these changes? Would this indicator and the base changes be at the 20 million mark, which is what we're seeing here on this screen here, is if we get $20 million or more, increasing the base for infrastructure.
This is, you know, this funding formula here could be applied for anything. So for any pots of funds, but, you know, if the legislature increases our investment and we have 35 million that's allocated to local public health, then this is the funding formula that would be used.
Veronica, if I may, I know that Excel can be kind of scary for some people. So if you're hesitant because Excel is scary to you and you don't have a question, but you really do have a question, feel free to ask, because that's what I'm here for. We can even kind of go over, you know, how did we even come up with this number? This doesn't make any sense to me. So if you have any of those kind of questions, feel free to please ask, because I didn't come up with this. I'm not the genius mastermind. I'm just the person who's upkeeping it. So if you have any questions that I can't answer, I will do my darndest to help you out. But yeah, feel free to ask away.
I'll just answer one of your questions, Veronica, which was if we stay at the same funding level, do I agree that we should leave the funding the same as it was before and not make changes so that we maintain the same level of funding currently and don't surprise any local public health with a lack of funding? And yes, I agree with that decision. So I think that was one question. And then there was the second question, which I think I need a little bit of clarity about how it would change the discussions that you had in the subcommittee would change the funding based on new indicators that you would that you may bring in for that you brought in for discussion. I need a clarification of that second
Thank
question.
you. So for the great question, we are not proposing any new indicators on this official vote. We had a lot of discussion on migrant seasonal farm workers. We're not bringing that in. I've taken the comments from Jocelyn and Kelly and Erica about that. No new indicators, but changing the percent distribution. And Drew or Victoria, I don't know if anyone has the slide that showed what originally the percentages were and what we're proposing it goes to.
Victoria, if you can unshare, I will share. It's a separate file. Okay.
And just again, the drive in changing those percentages was to follow in line with what we have organized as our drivers in health equity, correct?
Yes, so we took putting less weight on burden of disease and health status and moving some of that weight to community indicators, so community context versus that. But not, yes, go ahead.
And sorry, one more, an example of a community context, housing.
Housing is not in there.
Okay. I'm sorry, I just don't know which ones they are.
And so I'm hoping that we'll be able to share that in just a moment, because it is race and ethnicity, rurality, English language, education, income. I do not believe we have housing in there.
So for instance, if you have a county who has a higher percentage of people who have English as a second language, that county may be weighted more to get more funding. So that funding could go there to make a bigger difference in that area.
Yes.
Okay.
Do we, and I'm not sure you're sharing, but do we have, this is the Excel sheet, do we have the Word document that just shows the two side by side of the percents?
We do not have that in the packet.
Okay. Okay, so that was, Drew, do you by chance have that? I think that made it just was easier to see on one image, on one piece.
I can, if you give me a couple minutes, I can pull something together.
So if you can look along the row 8 that we're looking at right now, those are our indicators. And we see limited English proficiency, education. It's just that this spreadsheet goes through all the different iterations and changes. It's very nicely detailed, and it just may be beneficial to see what percentages were calculated. If you go to the county, the input or county data tab, will that give us a percents there as well? Yes, right?
This gives the proposed changed.
Okay.
Wait. So these used to be all equal, and they all equaled out to 16.7%. And rurality and poverty were actually each 8%, but because they were considered two measures of a single indicator for socioeconomic status. So the changes that Veronica's talking about are burden of disease and health status get weighted at a lower percent. All other indicators get weighted at the same 18%, and rurality and poverty are kept at the sort of, same level of all of the other ones instead of being half of one indicator.
So just to clarify, go ahead, please, whoever asking a question, go for it.
No, sorry, I was just, so this would, the previous, they were rated at 10.4% and now they're up at 18.
They were all
Okay.
rated at 16%. It's a little bit confusing. So this column C is, of all the funds that are available, 10% is going to limited English proficiency, but of just the funds that are available for the indicators, which is different, it's 18% of that total pot. And that's because, some of the funds are also going just to base funding for counties. So not every dollar goes to these indicators.
Got it. Okay, thank you. This is very helpful.
Thank you for asking for this clarifications. So no new indicators, a change to the base, increase the base, a change to the percentage of the distribution of the indicators is what we're requesting. Other questions? These have been excellent questions.
And that, sorry, I know, I
it's great.
apologize again.
No.
And that was approved by Chloe as well. I missed that part of the discussion.
Yeah, we have reviewed with Chloe and they've provided input at a couple different points over the last couple of weeks.
And I guess I just wouldn't necessarily say approved, like there wasn't that approval process, but they were in discussions and they presented a couple times to us. And I know that others from the group went and presented to Chloe. So I believe that it seemed okay with these proposed changes. Does that seem?
Yeah, sorry, it's wording, but yes, I'm with
just want
you.
to make sure. Okay.
Yep.
And I would like a clarification of something that I said, and I'm going to ask Sarah. Sarah, we would make these changes starting at 20 million. If we got at least 20 million, the changes we're asking.
If we make these changes to how indicators are weighted, then it's going to be used on all funding formulas moving forward. Okay. And the reason that's important is because sometimes other public health programs like tobacco prevention use this funding formula. And they likely don't have 20 million or more going out. One of the things that Chloe talked about this morning is, if FAB makes this change, then before any changes to actual allocations are made for funds going out to local public health, that always goes through a Chloe review and discussion process. So for new funds moving forward, this would be the one. These changes would be in effect for new funds moving forward. If the funding formula is already being used for some public health program funds, then Chloe and OHA staff would work together to figure out how to shift to these weights that FAB wants to use and how that would affect LPHA allocations and whether to make that change based on those conversations. So the weighted piece is in effect. If FAB approves, it'll be in effect for any funding level. But I think the caveat there is, but we don't want to make a change that's going to result in less funding for any LPHAs unless there's support for doing that. So while this would be the funding formula, we need to put it within the context of whether we're talking about new funds or whether it's going to impact current funds. And those conversations, I think we look to FAB to provide your input, but a lot of that would happen through conversations with local public health authorities.
And new funds is the biennium, the 2023. So this could go into effect for the 2023 biennium, 2023 to 2025. Okay.
Oh, Jocelyn, you have your hand up.
Mm-hmm.
You're muted, boss.
Can you, I was wondering if Drew could tell us, how is race ethnicity operationalized?
Could you explain what you mean by operationalized?
Well, what is the measure?
So like that comes from like the census data that comes out as far as who the certain ethnicity within a county. From what I'm understanding.
Yeah, it's ACS, and it's the percent of people who select something other than white, non-Hispanic.
Okay, cool. Thank you.
Thank you for that clarification.
And what percentage of that data is unknown? Do we have a good, I mean, from the data that I get from the CCO perspective, we, 40% of our race and ethnicity data is listed as unknown. So I'm just curious, in the census data that you're looking at for the population in these that are determining these numbers, what percentage of that is unknown? Do we know? Is that unknown?
It's unknown at this moment. Yeah.
Because if you're making a determination and placing a significant amount of weight of something, but you're actually only measuring less than 50% of that population, you only have the known race and ethnicity for less than 50% of that population, how are we going to account for that? Or maybe that's a question for the subcommittee.
Yeah, thank you for that. This is Nick. And I think, so that's a key piece of why we wanted to review the data sources as our next step. If we could agree on the weightings, that would be a first step. And then the next step was, what are the most sort of current and accurate data sources that we could use that help us understand the actual picture on the ground?
Okay, that makes sense. Thank you. Because I agree with the concept, but it's, yeah, you want to make sure you can get really accurate information. Yeah. Okay.
Other questions?
Can you clarify a little bit about how the discussion went? I know we don't want to pull funding from what, and I said that so quickly at the very beginning. Oh, I agree with your first sentence. And then as I sit and I think about it a little bit, I'm just curious, what was that? Was that a pretty robust discussion about because if you agree to these and you put them in, some counties are not going to get as much money. That's just the way it goes. Others are going to get a little bit more. It's going to all adjust. So I guess what was the discussion about waiting and doing it for new funding and not doing it for the basic funding right now? Because I mean, that is the transfer of power is what we're trying to do in a lot of our health equity discussions, right? And in this case, power, we're talking about funding money. So if we're really trying to talk about funding what we think is the right thing to fund and change these percentages, then why wouldn't we not do that now with the funding we have? Yes, I know it's a bit of a jolt to the system, but if the system is agreeing that that is the way to go forward, why are we stepping back from doing it with the funds we have now?
So my quick answer on that is we did not discuss that caveat. Our caveat was only changing the future funding for 2023 forward. So keeping what's already been discussed in this previous biennium and voted in as is, and just making these decisions with the new funding in the 2023 biennium. And please correct me, subcommittee members or Sarah, if I'm wrong on that. So we did not discuss that piece about, it wasn't discussed. I think we did have discussions about, yes, the changing of the amounts between the counties. And we had these in different meetings. We originally focused a lot on raising the base, so moving it up to 200,000. And Claude did come back and talk with us, and my understanding is that it seemed to go over pretty well with the Claude, that people were fine with raising the base. I don't, again, there wasn't too much concern when we looked at shifting the indicators, and Drew did a great spreadsheet. For most counties, it was really negligible, like at 1%. 2%, it was a couple counties, and we could bring that up where there was about a $50,000 swing. And I don't know, Drew, if you have that very detailed spreadsheet that we had up before that I said, please put down and put up the short one. And now maybe we can look at the very, very detailed one that Drew put together. And we didn't have any, we had discussion, but not, I don't recall a lot of discussion about this at this point. So if you look at what Drew did, is he put the different changes next to each indicator, and then and maybe we should have Drew explain, I'm sorry. We're really looking at the overall, the take home piece for each county, Drew, and how that change was. Is that what we're looking at here in row AD? Is the dollar amount change if we were to move base funding and indicators and column AG for percent change?
Correct. Column AD would be the overall difference. Current version is with the old percentile. Version 2 is with the new percentile. And then, so that current version would be AB, version 2 AC, and then the change. And you can see as far as percentage wise on AG, it's fairly nominal.
And I just want to clarify what I said. I had said this already takes into account raising the base. So this change only looks at the rate, what the indicators do. And so there were, if we scroll down to some of the larger, so we see here row 39, I have them somewhere in my notes, what that was, that county gets a fairly large increase, whereas row 41 gets a somewhat equivalent decrease. So I think we had that for about 4 or 5 counties with a fairly large swing, if we're looking at about $50,000. And I believe that this is in everyone's funding, in everyone's meeting packet. Maybe. Yeah. So we didn't actually have a lot of discussion. We discussed it, but we didn't have counter voices. Let me put it that way, Jeannie. I didn't receive any notes back or hear back from people about that people were concerned about this. And I don't know others who were at CLO today, or if you have other opinions from your counties or other counties, what the thoughts were on the indicator switch, or percent changes, I should say, percent changes in the indicators. Don't see any hands raised. Jeannie, I want just ask, since you had the last question, does this answer your question about discussions about concerns about, I mean, again, we did not discuss making these changes for current funding, only for future funding.
Okay, yep, that makes sense. And then so local public health will have this information ahead of time for their budgets for 2023 to know that this will be a swing for them one way or the other.
Yes, and to make sure that what I had said before was corrected, it is at any funding level moving forward for new funding.
Gotcha.
Sorry, that was my.
That makes sense.
Okay.
So
I do appreciate these very detailed questions. I do, and good. Thank you. It's very helpful to think these through. Other comments, Jeannie, questions, or others from the group?
I just wanted to have, this is Jackie, I came on late. I just had one clarification question. So by new funding, that refers to any future budgets, not necessarily like new funding that might come from ARPA, another equivalent of ARPA coming through.
That is correct. This is funding only through the general fund through the state.
Okay, and so this would be from the 2023 to 2025 fiscal years. Like this is when it's going to be in effect.
Correct.
Thank you.
I think, Jocelyn might have something more to share here. Any individual funding formula and decisions that are being made works through the CLO committee structure. So, there will be conversations at that level. I don't want to speak for local public health leadership. I know that they've had interest in having, one funding formula that can be used for different funding streams where it makes sense to do so. Sometimes it doesn't for, various reasons. So I think the intention would be to move to this model, just realizing that sometimes with different public health funding streams, there might be some conversation between local public health staff and the CLO committees and then OHA staff to figure out the best way to get to that. Jocelyn, am I getting this Is this how you would see it working?
I think so. But for modernization though, we don't have that. That's dictated by FAB, right? Okay, good. Yes, I do think that there was in CLO, there was, you know, a real recognition that the smaller counties have been sort of hamstrung by this inability to hire because they don't have enough funding to hire a whole FTE, you know, and it's just really challenging. So these higher bases are an acknowledgement that we really need to support those smaller and frontier counties to be able, and it gets complicated because of course just having the funding is not their only crisis. Having, you know, nurses available in those frontier counties is really important and not available right now, and so they have other challenges as well, but this is at least one that we can try to support, I think, as a system, and then have to try to put other strategies in place to help with the, you know, having people available to actually hire once you have the funding. So that's a whole different question that we also have to work on.
And Jocelyn, thank you for adding that point. And do you have any comments or feedback about that you might have heard about the indicator percentages?
I don't, there didn't seem to be a lot of, there certainly wasn't a lot of pushback around the burden of disease and health status being sort of deprioritized, but also Sarah noted that those were in the original legislation, so they weren't something that we could not include at all. And I still think it makes sense to include them. I think there's a reason why they were in the legislation too, that, you know, burden of disease is important. But I think, yeah, people were supportive of these others being given a higher priority.
Okay, thank you. Any other comments or questions before we move to a vote? And we'll make sure to be clear what we're voting on. I'm looking for any more hands, but I'd like to say how much I miss Bob today, because Bob normally does our subcommittees summary and questions and all the historical knowledge. So let him know. All right, so then I think I don't see any more hands raised. We can maybe move to a vote, and I'm going to say it. And if I've said it wrong, please correct me. So we are requesting to make a change to the infrastructure, so raising the base 200,000 and making a change to the indicator percentages. So again, like I said, deprioritizing burden of disease and increasing those in the other indicators that we saw. This would go into effect for any new funding and specifically the 2023 and forward biennium 20. Is that correct? Did I say that correctly? Okay, so all in favor for a yes, please raise your hand or use a reaction button. Okay, Sarah, do you have everybody counts?
I think I have all the yeses.
Okay, so if you'll lower your hands down and then make sure all the hands are lowered before I start. Now, any votes to not approve this decision and to not approve the request to change the funding formula? Sarah, are you good on those numbers? Okay, and any votes to abstain from this vote? Anyone wants to abstain? And do you have those numbers? Okay, great, thank you. Those who raised your hand, you could lower those. And then lastly, do we need to do a formal vote on, Sarah, the report?
I think you probably want to do some version of a vote on just giving a recommendation that OHA move this forward within the next 10 days or so to Legislative Fiscal Office.
Okay, so our next vote will be to vote to have OHA move the funding formula and the accountability changes to the legislator in the next 10 business days, end of the month.
Yeah. Do you want to look at the report? Because the other piece of the report is the funding estimate, the ask for funding for the next biennium.
Sure, if you'll please share that.
Okay, so you all have this through email. It wasn't included in the meeting packet, but it was a separate attachment. Still in draft form. And I think that FAB is pretty familiar with most of what is in here because it's about how funds were allocated and used by local public health authorities, federally recognized tribes in the Urban Indian Health Program, and by community-based organizations and OHA. So I'm not going to go through the whole report, but we want to make sure FAB is aware of the proposed 2023 through 25 investments that are included in this report. So FAB had discussions early this year about how you would envision additional funds being used in the next biennium. And that's what you see here on the screen with these 4 points. So using funds to build on the lessons learned from the COVID-19 pandemic to respond to and mitigate emerging public health threats, investing in governmental and community public health initiatives that engage people in Oregon directly, investing in public health workforce development and retention, and then resulting in funding would result in broad implementation of public health modernization across the public health system. So, instead of only focusing on communicable disease control, really thinking about how the infrastructure of public health modernization is applied to all of our public health program areas. So the amount that the estimate that's going into this report is for an additional $300 million in state general fund for the next biennium, which is very large. OHA has worked closely with local public health leadership to develop what the work would look like and then hear from them the amount that would be needed to do that work. We followed a similar process with community-based organization leaders to hear from them about what they envision the work being and then what the cost would be. Dana Drum is on and she's worked with every federally recognized tribe, NARA, the Urban Indian Health Program. And then OHA has also priced out our state pieces. So that's where that number of an estimated 300 million comes from. I don't think I mentioned, so within this, it would be 100 million going, additional funds going to local public health authorities, 100 million going to community-based organizations, and then the funding for the federally recognized tribes in OHA is in that last 100 million.
Yeah, if I could, so I'm just curious about how the 100 million the local public health went through and the state went through an extensive assessment when we first started modernization to be able to put a dollar figure to what is needed to bridge the gap between what we saw currently in local public health and what the modernization manual represented in terms of services. And I'm wondering, how was that done for CBOs to arrive at that same number?
Yeah, it was a very different process. And then it was a different process with the federally recognized tribes as well, because the tribes have not done a cost assessment like local and state public health did. So for community-based organizations, it was sort of a 2-pronged process. First, talking about the different bodies of work and trying to come up with just an estimated cost for what it would mean to put a significant investment into those areas. And then the other piece that that group looked at was the funding requests that we got in this current biennium. So for CBOs, there were requests for somewhere around 130 million. We funded very little of that because we have 10 million in funding going out for public health modernization. So just understanding that even just on the first sort of application for funding, that's the sort of gap that we were seeing.
Well, just maybe as a follow-up, how was the 130 number arrived at?
I don't remember what the exact number is, so it's now in the meeting minutes, but don't quote me on it. So that was the amount of all the applications that came into OHA in January and February. That was the amount that was requested. Victoria, I'm wondering while people ask questions, if you could pull up the health equity review questions for the LFO report.
Sure.
I think when I was reading the priorities there, in the first document that you had up there, it didn't say anything about our kind of our anti-racist way of going forward, looking at things. I mean, the reason why we just adjusted the weighting of local public health dollars was to make sure that we were using indicators and metrics that were based on language preference, race and ethnicity, and move away from kind of a traditional way of thinking. But when then you look at the way it's presented to the budget office and for fiscal, there's nothing mentioned in that document. And maybe it's mentioned somewhere else, but in that one page we were looking at, there's nothing mentioned as the priorities are adjusted because of what our priorities are focused on, which is removing, working specifically with populations that have been marginalized and removing health inequities and health disparities and racist policies that are in place and so forth. So I'm just curious, in that document and the writing of it, where is that emphasis so that the people who are looking at this as the request for the budget, they understand this budget is changing for those reasons? I don't know, maybe that's not necessary. This is straight up finances. I don't know.
No, I would say, well, I don't want to speak for FAB. That seems important to emphasize in how we're communicating about the changes that are happening in the public health system and the vision for moving forward, and really the focus of how funds would be used.
There is in the very beginning of the document. I mean, it says, public health threats affect every person in Oregon due to policies that have long created unequal conditions for health. So it's written in the body of it. Maybe it's just not written on that particular page. But
I think since those points, those dot points that I was showing are intended to reflect FAB's priorities, if you want a change that more clearly states funds will be used toward achieving racial equity in Oregon, or however you want to phrase it, that addition could be made.
Second addition. Definitely. I think there's an element here where if it's not expressly connected to the money, then there's a way people can just kind of hand wave and be like, oh, we generically and generally uphold these values, but then you can't actually point to how the resources are being used specifically for those purposes. So I do think there should be something that's woven expressly throughout every line item as necessary and appropriate.
And I'm sorry, I can't understand what you're saying, Dr. Pettaway. I heard throughout every line item was the only phrase that I heard. Could somebody repeat what? Right, I'm sorry, it's just the audio isn't very good.
He basically said that, yeah, if you don't tie the funding to the priorities that you have put in there, specifically
Mhm.
about what our priorities, then there's a way to just kind of see that and use them for whatever, other areas. But if you specifically, and then he said on every line item, if you can connect the purpose to that, then it's more clear that the purpose and priority is for, I'm just going to say in a general way, anti-racist activities, anti-racist work. He's so much more eloquent than I am, but I think that was the gist. Sarah, I'm not sure. Did I capture that?
I think so. I would ask Ryan if that captured.
Yeah, Ryan,
Yeah,
sorry.
Yeah, definitely. Is this better? Is this kind of working?
It's like staticky or something.
Yeah, it's
Yeah, I don't know. It's the computer. It's always having problems. But yes, that was good.
okay. Thanks.
Can FAB members give us an item to add to this list, probably at the top of the list that frames that out, or that puts it in a statement that you would want OHA to be using?
I'm sorry to be so I have so many comments today. You guys, I shouldn't have had so much coffee. I think that even just adding something in each statement, for instance, the first one, build on lessons learned from COVID-19 pandemic to spread to pandemic to respond to and to mitigate emerging public health threats, especially in the most marginalized populations, or especially specifically in BIPOC communities or marginalized populations, something on that line, and then invest in governmental and public health initiatives that engage Oregonians directly, or that engage people of color directly, something as direct as that. That's kind of how I would look. Sorry, Ryan, I went ahead. I've not been good at raising my hand today.
I'm just going to second that again. And I think another example, if folks can hear me, would be like the part about workforce. It's vague, right? And I think as I'm doing this survey related work and everything, I think there's room for us to be specific about who we are including in the workforce and who isn't represented within the workforce, right? And so I think part of this has to do with like, are the folks that are living in rural communities actually getting NPHs and then becoming a professional for those communities? Or all the representation within public health offices coming from cities or other states and then actually from those communities? And so I think that something that specifically says we're going to try to, not only diversify racially, ethnically, right? And also in terms of like gender and representation, all those things, but also like we should be explicit about trying to like, grow our own, so to speak. And I think that like there's value for that within low-income communities of color. And I think there's value for that for smaller rural communities. Because I feel like on some level for this work to really be successful through all of these different levels of these priorities, I guess, it seems to make sense that folks are, able to represent themselves in these spaces. And I just think that we should just call that out and call that in and try to craft what we can to make that happen. I think it'd be amazing to see an epidemiologist born and raised in a rural Oregon community go and get NPH and go back and be the epidemiologist for that town. Like, why does this epidemiologist have to come from the University of Washington? Like, why and never have lived in that county before they got the job? I just feel like we should be deliberate about what we mean by workforce.
Did we want to specify a rural in that third bullet point? I think whoever was typing has done a great job of adding in others, but I don't know if we want to put anywhere. Okay.
Yeah, sorry, I missed that. You do want to add in rural?
Trying to read Dr. Pittaway's notes too.
I would suggest yes, and while you're reading his notes, but yes.
Great, thank you. And Jeannie put suggested edits there.
I'm just wordsmithing in the chat.
Yeah, thank you, Jeannie and Dr. Pittaway, for doing that as well, for bringing those up and giving suggested wordings.
Yes, and calling out Oregon's federally recognized Indian tribes as well.
That last note I put in the chat doesn't need to be in the document. I just think that that's something for us to think about.
I can say, you know, in both the conversations with local public health leadership and with CBO leadership, these are the exact conversations they're having. So, you know, what you have here is a 4-item list that tries to synthesize it, but the very detailed work that they have been talking about underneath that work is exactly these issues around a workforce that's representative of the community served, of developing the workforce from communities, thinking specifically about how we support public health workforce in rural areas of Oregon. So all of these themes are things that local public health envisions as work that needs to happen. CBOs are also talking about it, and sort of what the CBO role is within that, which is, you know, very different than local public health role.
And Sarah, did you get the edits from Jeannie and others too about adding in rural and tribe? Okay. Okay.
Yes, we've got everything that's in the chat.
Are there any more discussions on these points here? And then if not, if there's other discussion questions. I guess I have a question on the funding. If you don't get the 300 million, is it just a percentage then? So then whatever amount you get, that percentage is split essentially in thirds among OHA, local health departments, CBO?
And the federally recognized tribes as well.
Okay.
So how we've done it in the past is it's proportional. So the ask is, you know, 300 million, and local public health piece of that is 100 million. So if we get half the ask, then LPHAs would get a 50 million increase in funding. And that's one way to do it. I think the nuance would be is if the legislature told us that they wanted some specific things prioritized, like around community-led data systems or something like that, that might provide a different lens for thinking about how to balance the funds with the priorities.
Thank you. And then the allocation for tribes is within the OHA. That's in that piece there. Within the
it's within the 100 million because the federally recognized tribes, and Kelly can speak to this, have been doing like very detailed work thinking about the amount of funds that each tribe would need for their specific tribal priorities. And so, you know, we're still figuring out exactly what that amount is. We're also still working to price out some of the OHA like positions, as we need to do for our positions. So,
okay, thank you. And Jawad added a comment about adding in refugee populations to the discussion or to some of these points here. Thank you for that. Other questions or comments or edits?
So Sarah and Veronica, just for point of clarification, you're hoping that we can vote on this today, correct? Is this a vote item?
That is my understanding. Correct, Sarah?
it is a vote for OHA to be able to move the report forward. This is not a FAB deliverable like the first two items were.
I'm just wanting to make a clarification that you guys can make the changes on the document and we don't need to bring it back. Like, we can trust that the sentiment that we're giving you, that these feelings and get put through on each one of those points can be taken forward, and then we don't have to delay this encouraging the OHA to put this forward. Is that correct?
You can, so that is great. And if members want a chance to say, you know, this is generally correct, but if FAB members want a chance to provide some edits, then we can do a cleanup this afternoon and send it out to you all and give you about, you know, a week to provide comments. It would still be helpful to have a an action today that says this is, on the right path and OHA can move it forward.
I think that's a good suggestion. I think that seems great. That way others can see the version in case there's other edits to make. Other comments or discussion before we move to a vote? So the vote they were asking for FAB is to approve OHA or recommend that OHA forwards this report up to the legislator, making changes that were discussed today in this meeting. OHA will send a more detailed drafted version out to the group with any edits needed in the next week. So if those members of FAB would approve this recommendation, please raise your hand or move your hand up in the reaction button. Great. You have everything, Sarah, for that count. Great. So please lower your hand. And then our next will be FAB members who vote not to approve or recommending sending this report. Okay, and then any FAB members abstain from this vote. So Sarah, you good on the counts?
We're good on the counts.
Okay, thank you everybody for a very, very thorough discussion. I suggest that we're about 10 minutes behind schedule, but I still think we should take a 10-minute break and we'll just shorten our charter and bylaw review time. So just take a 10-minute break. We'll come back at 3:45 and we'll start with Dana Drum and the Preventive Health Services block grant. Thank you. Thank you for those of you who are returned. Dana, we'll just take another minute, but if you want to get ready to present, and Dana, feel free to take the full lot of time and originally scheduled, and if you need longer, to make sure we have a good discussion of this.
Thanks. And Veronica, just to let you know, my name is pronounced Dana. If you remember,
Dana, thank you so much.
If you remember Rosanna Dana from Saturday Night Live,
yeah,
that might be an easy way to remember it.
Dana, thank you for correcting me. I appreciate that, and I appreciate you doing that in front of everybody so they don't repeat my mistake. Thank you very much, Dana.
Great.
Thank you. So we'll actually go next. So Dana will be walking through the proposed OHA block grant, the work plan for the next fiscal year, and will be focused on the content in the health equity review and policy procedure. So Dana, I'll pass it over to you.
Great. So hold on, let me move my screen so I look like I'm looking at you as opposed to away from you. So it's good to be back with you. I think it was last month I came and talked a little bit about the block grant and kind of what it's done previously. This year I want to just to kind of reset, or this month kind of reset. This is a non-competitive grant that's issued to all states and territories by CDC, and it's in legislation, federal legislation that guides it, and the Public Health Advisory Board has been designated as the Block Grant Advisory Committee. And so that's why we're here, to get your input and feedback and recommendation on the proposed work plan. As a reminder, there is a portion of the dollars that are set aside for rape prevention and sexual violence assault services. And interestingly enough, this year, there was actually an increase in that allocation. Instead of a little over $85,000, there's a little over $88,000 for that funding. And I actually don't know the reason for the change, but that was what came to us from CDC. The work plan needs to be tied to Healthy People 2030 objectives. And as I've shared previously, Oregon has typically used the block grant to support infrastructure because for many, many years, it was the only flexible funding we had. Though not a lot, it was flexible, and we didn't have another source to fund some of the work. What's exciting as we move into looking at the next year, which runs from October 1st, 2022 through September 30th, 2023, is that we are making some pretty significant shifts. So for years and years and years, this funding has really paid for the local public health liaison roles in the Office of the State Public Health Director. And we are taking those roles out of this funding stream and doing so intentionally to create more funding to be available to support strategic initiative work, and especially Healthier Together Oregon, the state health improvement plan. And so as we think about the questions that the FAB considers around equity, this is a big shift. It's not that those infrastructure pieces previously didn't support equity. They did in terms of supporting local public health authorities and federally recognized tribes. But this funding will able to now, there will be more funding to be more responsive to the Healthier Together Oregon needs. So that's super exciting. We will also have a transition where as of October 1, Sarah Boudreau will be shifting to move into the Block Grant Coordinator, since she is the lead for the strategic initiatives work. And so you will see that there still is about a third of the funding that will support some of the public health modernization work. But again, this is just a really exciting shift, and it has been a goal of mine for a number of years. And so it's very exciting to be in a place where we can make that shift. So with that, let me just give you a high level overview of the types of things that'll be covered, and again, how equity gets infused into that. So there will be funding to support Healthier Together Oregon implementation. And as has been shared previously with this group, you know, we don't know completely what that will look like, because the partnership, which is that group of representatives from a variety of communities, they really make the decisions about budget allocations as it relates to Healthier Together Oregon. And so this funding will provide ongoing support for the partnership, in particular, continuing to support the Strategic Initiatives Coordinator, and that's Christy Hudson, so that we have support to keep the Healthier Together Oregon work going. It will also continue to support some of the partnership meeting facilitation and partnership member compensation and travel, but we will have more funding to for the partnership to use to do things like mini grants, communication tools, training, kind of what are some of the things that would be needed to support those 7 prioritized strategies that the partnership identified. So those were around housing, some things around healthy and culturally appropriate foods, particularly for communities that have traditionally experienced health inequities, building a resilient food system, reducing systemic barriers to behavioral health services, providing culturally and linguistically responsive trauma-informed behavioral health services and supports to children and families, improving integration between behavioral health and other types of care, and increasing affordable access to high-speed internet in rural Oregon. Now, this funding is not going to solve all of those problems. It's not a ton of funding, but it is significantly more than has been available, and may be able to be used to provide some seed money for some projects. In terms of the public health modernization support, Sarah's position will move into this grant because she is the Block Grant Coordinator, and there's a requirement for a Block Grant Coordinator in the funding. So there's money to help support that and her ongoing support with the Public Health Advisory Board. If there were potential need for training for the board or development opportunities, there's a little bit of funding that could help support that if that were needed. We've also put in here some funding to help support training for local public health authorities, tribes, and CBOs to support modernization implementation. One of the things that I had a conversation with a public health administrator about was, gosh, it would be really cool for public health administrators and tribal health directors to have the opportunity, if they wanted to opt into a health equity leadership cohort and do some kind of training that way. And so this would give us some flexibility to really identify the need and work on that. We will continue to provide a very small amount of funding. It's like $5,000 to the Conference of Local Health Officials for ongoing work to support those meetings. You all are experiencing, and particularly over the last few months, the importance of that connection with the coalition or the Conference of Local Health Officials. And so this will help support that. And then staff, as I mentioned, sort of that ongoing staff support, particularly through Sarah's leadership around things like accountability metrics development, the report that you just looked at, and coordination with local and state partners. Finally, the sexual violence primary prevention focus. So the Oregon Coalition Against Domestic and Sexual Violence is the recipient. They'll be receiving a whopping extra $3,000 or a little less than that this next year. They look to continue to fund 1 to 3 local culturally specific organizations and or tribal sexual domestic violence programs to really continue to build that capacity for primary prevention and programs. The funding for sexual violence work typically is on the services side, and there's actually very little funding for the prevention side. And so this will enable them not only to fund in a small way, a few organizations to do that work, but then also have staff capacity within their organization to provide support and training and technical assistance across the organization, sexual assault services organizations that they serve. Finally, and I apologize for the wonky formatting on this. I don't know what happened to this document, but we did get our allocation finally, which I don't believe we had when I met with you last. It's a little over $1.1 million. It's in the ballpark of what we have received for the last several years, so there were no surprises there. You see the set aside for sexual assault prevention and services. We roughly about a third of the funding would go to the state health improvement plan work. Another third, or $353,000, would go under the Healthy People 2030 objective. It's called financing public health infrastructure, but it's the objective within Healthy People 2030 that calls out the foundational programs and capabilities. You see the 88,000 for 458 for reducing sexual violence. And then there's a 10% cap on the indirect costs that the state can charge to our portion. And just to note that that doesn't cover all of our indirect rate costs. So we end up using some of that general fund that is allocated to the public health division to make up the difference, because I think our rate ends up being around 17% or so. Staff-wise, we've got 3 FTE. The Public Health Modernization and Strategic Initiatives lead, that is Sarah Boudreau. The Cross-Sector and Strategic Initiatives Coordinator, which is Christy Hudson. And then it won't be for a full 12 months. I think it's more for 9 or so. We will have an FTE that will be the Safety Net and Policy Coordinator, and will help with the implementation of Healthier Together Oregon as well. And we also have an intern who's going to be joining us on a very kind of very part-time basis, but this will help cover her compensation. We did hold the public hearing on Tuesday. We had, I think, 2 organizations join. There was no public comment. I'm always heartened when someone joins, because often it's not a well-attended public hearing. And often the people who do attend, they do so just to learn more about the Preventive Health and Health Services Block Grant. And I think that was the case based on what people shared about being there. So with that, this is what I have before you. To FAB doesn't approve it, but we do need a kind of a recommendation that FAB supports this moving forward and the general direction of it. And I'm happy to answer any questions.
Thank you, Dana. So maybe we'll open it up to questions. Oh, Jocelyn. Dr. Warren, please go. Your question.
So I'm curious about the implementation of the prioritized strategies, with the examples being increasing access to affordable, healthy, culturally appropriate foods, decreasing barriers to behavioral health services. So these are, of course, also included in our local community health improvement plan too. And we've put a lot of work into coordinating those efforts across partners when we are looking at doing the community health improvement plan and strategizing around who's doing what and how we measure it and working on collective impact. Is there thought being given to how we can use those existing structures too, so that you're not making creating additional parallel efforts in the communities and that you're funding, or how can we make sure that those things are aligned, and you're not funding local work that is not connected with our local plans? That the plans themselves are very much aligned with Healthier Together Oregon.
So I don't know if Sarah is able to address that. I mean, I can take a stab at it, and Sarah can let me know if I'm wrong.
Yeah, go for it.
Okay. So I think generally, in general, I think that certainly when we've written the block grant and when we've included the state health improvement plan previously, I think we do want those, the state health, that synergy between local plans and the state plan. I would hope that, and I know that there's tribal representation, and Sarah, I can't see you. There is also local representation as well on the partnership, I believe. I think it's Jennifer Little from Klamath County, and I don't know if there are others. Am I correct about that?
You're correct that it's Jennifer, and I do think she is the only local public health member right now.
So I think that there has been a real effort to have the we have had previous versions of the state health improvement plan that were very sort of executive directed quite some time ago. And I think there's been a definite effort in the work that Christy has done through this to make sure that what is emerging and gets elevated in Healthier Together Oregon reflects community needs and reflects also what is in local plans, and then ideally vice versa. So my hope and expectation would be that as the partnership comes together, again, including some local public health representation, that as they think about those dollars, and if they are going to send dollars out, that there would be that local tie. Because it makes sense, right? That like if transportation is a priority and you're going to provide some seed funding, that should probably go to a community that has identified that as a need. And but at the same time, I think there's a desire for OHA to not directly direct, that sounds funny, but to direct exactly how that needs to look, knowing that the partnership, wanting that to be driven by the partnership. Anything you'd add or correct, Sarah?
No.
Jeannie.
I'm going to sound like a bit of a broken record, but as we look forward to continuing to updating our documents and reflecting our desire to put anti-racism and our work and working with populations that have been marginalized upfront and forward in the work that we're doing, once again, I see this document and I don't see that specifically called out. And if we're the advisory board and looking at this work, I would say, for instance, just a call out, the block grant has a Section 4 rape prevention, and this funding currently goes to the Oregon Coalition Against Domestic and Sexual Violence. That's great. I'm wondering, do we know what kind of, is this the only place it should go, or is this group serving our marginalized and BIPOC populations? What are we doing to make sure that all of the work that we're funding through this block grant is once again prioritized with the health equity lens that we've been putting forth as our strategy? And if it is, that's great. Just need to document it.
Great. Thank you, Jeannie, for that feedback. I will say that the work that the Oregon Coalition Against Domestic and Sexual Violence has been doing is very much from the lens of BIPOC and other disproportionately affected communities. They've done a lot of work with the Micronesian community, for example, in their primary prevention work. They've also done some significant work with the Latinx community as well as one of the organizations funded, and then also some in Southern Oregon, kind of in more rural Oregon. So yes, and I appreciate you calling out that needs to be reflected here. And as Sarah and I go to this, actually is not what gets submitted to CDC. It's we have this very cumbersome electronic system we submit through and narrative, and we can make sure that that gets that those priorities and the priority of equity get called out throughout.
Thank you. Yeah, I mean, maybe we can even use some of the similar language we used in our last document. That way we can just be consistent in the language that we're using.
Mm-hmm.
Yeah, I kind of like the idea. Maybe we'll just laminate it. Remember when we were actually in person, we had our health equity definition laminated in front of all of us. So, and you know, just so I just think that the calling out of our populations as well, that we do want to serve using BIPOC and our federally represented tribes as well. I know that Kelly's really good about bringing that up, and I don't want that burden to be just on you, Kelly, to be the one to bring it up. We need to bring it up as a group more frequently. So I think making sure that we're recognizing all groups, and specifically our federally recognized tribes and BIPOC as well, and so forth. Need to make sure we all do that.
And I'd like to say, I mean, I think also this shift to not including, so for example, as of October, well, actually it hasn't been, but for part of this year, traditionally all of the work around within the public health division related to the OHA tribal consultation policy, all of the work to do support for local public health authorities, all of that has been grant funded. And what we're doing is a significant shift that recognizes that that work with tribes, that work with LPHAs is actually just core work of the division that serves the division as a whole, and then enables these funds to more directly be used to support more health equity work. So I think it does a couple of things. It recognizes just that tribal piece is really critical infrastructure, and it's just part of how we need to do business along with the LPHA piece. And it allows us to use this funding in a way that I think has a really good intention, and I think fits more with the direction that CDC would like to see this funding used.
Anna, thank you for bringing that up, because that was my question. So those, I like that it expanded, but those positions are still there, but just with core funding. Or
yeah,
not.
They're not going away, and they will become part of our cost allocation pool. And actually, when they looked at it and looked at like what the impact of that is, it's actually very little. When our team actually, you know, we actually do serve the entire division, so that's a perfectly appropriate thing to be cost allocated. And I think CDC would really like to see these funds used for things that you know, wouldn't otherwise have a funding source, and also could be seed money that supports eventually more sustainable program.
Great, thank you. Any other questions or comments about the block grant? Okay, so we're not voting, but I would like us to maybe do, we're not, it's not, but maybe a recommendation, maybe a vote to recommend this block grant, the funding allocation and priorities as described. So our vote is to recommend the block grant funding and priorities as described in this presentation and in these notes. So if we'll have FAB members, please, if you agree and vote yes to recommend this, please do so in your camera or the reaction to raise your hand. And do we have all the counts? Can we lower Dana or Sarah?
Oh, sorry, I wasn't counting. I hope Sarah was.
I was counting.
Very good, Sarah. Okay.
I got the yeses.
I didn't know that was the other duties as assigned.
Thank you. So please lower your hands, and then our next is to, for those who do not vote against recommending, to vote against recommending this plan, or do not support this plan, please vote. Again, raise your hand or in the window or in the chat reaction. And I'll see a comment from Nick Powers in the chat, please, about his vote. And then now we'll please raise your hand if you wish to abstain from this recommendation. And Sarah, are you good on all of our counts?
Yeah, we have 7 people who voted to recommend and 1 person who abstained.
Great. Okay. Thank you so much for everybody. I think we're done with that portion. Dana, thank you very much for presenting all of this and coming back. We are at our next section, but we don't have time to go over our charter and bylaws review, but I very much appreciate the thorough discussion points, comments that we had, and actions that we approved today. So we did a lot of work. Pat on our back, great job. So we are not going to discuss the charter and bylaws in breakout groups, but I'll give you a taste of what we would hope to do, and we'll just move this to our next meeting. But we do want to start making actual edits to our charter and bylaws. So our plan then will be next month. Yeah, perfect. Whoever's changed slides, perfect. We have our authority. The red notes has already been changed, but we have our authority and purpose. We have our FAB duty, which is 2 slides, A through K. A through K, yes, A through K. And then we also have our charter, which goes over our organizational structure, which will go at the meeting following. And we'd like to do breakout groups where we actually spend about 20-30 minutes editing a section of the document, coming back to the group, sharing those proposed edits. So just to give yourself some heads up about what we'll be working on in a future meeting, and we already have some edits that have been sent to us by people who weren't here today, so we'll start incorporating these. These are all proposed edits, just a way for us to start making edits. At the next meeting, we'll be working on those edits. We will not be voting to approve those. It will just be a working meeting to start thinking about how we make some changes to our structure, priorities, initiative, and of course, that'll have to get approved by the Oregon Health Policy Board. Any questions about our charter and bylaws review, which we're not doing today, but any questions about that process? Okay, seeing none, we will move on to public comment. I know that Kara's received a request to provide some public comment in the meeting. Sarah will facilitate. So I don't know, I know we might have some that's been read in and we might have members from the public. Sarah, I'll pass this over to you to lead this section.
Great, thank you. I think Victoria is going to move to the end of the meeting packet where we have the written comment that was provided. And then for any members of the public who are on the phone or on the Zoom meeting today, we'd like to offer you time to provide public comment. So if you would like to provide comment, could you just signal to us that you would like to by either telling us verbally or dropping a note into the chat, or if you're on Zoom using the raise hand function. So a call for anyone who'd like to provide public comment.
This is Molly Kyle. I'm on the phone. I would like to provide public comment.
Great, thank you. Great. Is there anyone else that plans to provide public comment today? Okay, so we'd ask that you keep your public comments to somewhere around 2 minutes. And if you can go ahead and state your name again so we can make sure to capture it for the minutes, that would be great. And then please go ahead.
Thank you. So this is Molly Kyle. Can you hear me?
Yes.
We can.
Great. So my name is Molly Kyle, and I'm an advisory member of the Oregon Health Authority's Childhood Lead Poisoning Prevention Program. I'm also a professor at Oregon State University and am one of the Oregon's Environmental Quality Commissioners. I appreciate the opportunity to come before your board and make a public comment regarding the need to include childhood blood lead testing as a CCO metric. All children enrolled in the Oregon Health Plan are required to receive blood lead tests at age 12 and 24 months, yet Oregon has one of the lowest childhood blood lead testing rates in the country. Surveillance data provided by the Oregon Health Authority shows that only 6.2% of the children on the Oregon Health Plan had a blood lead test in 2020, and that decreased to 5.5% in 2021. So this is dismally low, and it is very concerning.
Childhood lead poisoning is a silent epidemic in the United States and disproportionately affects children who are living in poverty, who are living in older homes, who are not white, and who are recent immigrants, characteristics that overlap considerably with the children who are part of the Oregon Health Plan, and these children are not receiving their blood lead screening tests. As you may be well aware, lead is a potent neurotoxicant that targets the brain and the central nervous system. Elevated blood lead in early childhood manifests as decreased intelligence, increased impulsivity, decreased ability to pay attention, and diminished academic achievement. It's likely that elevated lead levels are also linked to slow growth and development, hearing, speech problems, learning, and behavioral problems that can persist throughout lifetime. Thus, early detection and early intervention is crucial. Fortunately, Oregon has an excellent and funded childhood lead poisoning prevention program that includes surveillance, clinical and laboratory experience, and trained environmental health specialists at the state and the county level who can investigate cases and identify and mitigate lead hazards. Additionally, the Biden-Harris Build Back Better infrastructure program has money designated to help communities mitigate lead hazards that are found in their drinking water distribution systems and the lead paint in older homes. This means that all the components needed to address childhood lead poisoning are in place and are currently funded for the first time in history. So the only thing that is really missing is the blood lead screening part that identifies children with elevated lead levels and gets them into these intervention programs. So this is where your board comes in, and the CDC, who provides funding for many of the childhood lead program activities in Oregon, has really requested that Oregon increase its blood lead screening activities. And as you know, what gets measured gets managed, and that is the power of the CCO metric. So on behalf of the Advisory Board of Oregon Health Authority's Childhood Lead Poisoning Prevention Program, we believe that adding childhood blood lead screening to the list of CCO metrics is both necessary and timely. This action, which you can take, will prevent lead poisoning in Oregon and among the most vulnerable children. So thank you for listening to me. I'm very grateful to the service each of you provide to the state on behalf of all Oregonians. Thank you.
Thank you for providing comment today. Are there any other members of the public who want to provide comment to the Public Health Advisory Board today? All right, Veronica, I don't think we have anyone else.
Great, thank you so much. I'm glad we had public comments. So that's exciting. So thank you. And our next meeting agenda items, anything to add to the next meeting agenda items? We will be doing a review of some of our bylaws. Sarah, what else is on our next meeting agenda? Do we know, or other items people would like to have included?
Veronica, this is not about that. This is about the public comment that we received. I just don't know the process as to how we as a board then take the public comment and talk about it, or how we then decide about the request is that our committee consider making childhood blood level to lead testing a metric on the Oregon Health Plan. And so since that is not our direct function as the FAB, but we can discuss how do we support that or take it to our partners where that may be done. I'm just curious the process when there's an ask made of us, how we go about responding to that ask. Since we haven't had it very much.
Yeah, I will ask Sarah if she has any procedural pieces on there that you could add to the logistics for us, Sarah Boudreau.
Yeah, I think, one option is for members of the accountability metrics subcommittee to ask that we hold this so that this topic can be discussed in that forum. While FAB, obviously, it doesn't make set incentive metrics for CCOs, there are public health functions related to childhood blood lead testing, and that might be something that the subcommittee wants to discuss.
So bringing this up,
I think any member could also recommend that the person who provided comment also share this with the OHA metrics and scoring committee as well, since that is the group that sets metrics for the CCOs.
Great. So we could ask Molly Kyle to share this to the other OHA metrics. And is this something that could be discussed in our accountability subcommittee as you're looking at metrics?
I mean, I'm on the subcommittee. I'd be willing to discuss it for sure.
And Jeannie, would we want to bring lead screening and lead exposure as a topic to our future FAB meeting?
I think for sure, maybe after we discuss it in the subcommittee and and discuss the request, and then maybe a recommendation we might want to take to the FAB, and then have the FAB agree or not agree to that recommendation.
Okay, that sounds great. So Jeannie, thank you for offering this up and for bringing up this comment. So discussing this in your accountability subcommittee, once we talk about metrics later in the year, maybe asking Molly Kyle or Ryan Barker from OHA to come, or somebody from their group to come and talk to us about lead screening numbers, programs, and then making sure that we can get this public comment forwarded to the other sister subcommittee, or sibling subcommittee, I should say, sibling subcommittee, OHA metrics and scoring. Great. Good suggestions. Okay, other comments for upcoming meetings? Okay, if not, we will adjourn early. And we will see everybody right now in July is our current standing time, but please respond to Tambi if you received an email about changing the time, so looking at your schedule. So have a good rest of your Thursday.
Thank
Bye,
you. Great
everybody.
meeting. Bye. Take care.